you could take your seats, and then we will get the AGM underway. We don't have a huge amount of time, and there's a lot to talk about, so the sooner we get started, the better. So please take your seats as swiftly as you can. Thank you very much. Good afternoon, and welcome to this annual general meeting of NHS England. It is a chance to hear about the 5-year forward view, about some of the new initiatives that the NHS is working on, how it plans to address the challenges of today as well as the challenges of tomorrow. And it is also a chance to put your questions to the key decision makers in the NHS. Some of those have been submitted in advance. We'll also be coming to you to put your questions in person, and we will get through as many of them as time permits. So welcome to you all, and I'd like to begin by asking the Chair of NHS England, Professor Sir Malcolm Grant, to get things underway. Malcolm.
Thank you so much, Michelle, and thank you everybody for coming tonight. On behalf of the board of NHS England, I extend to you the warmest welcome. It's only 2 years since NHS England has been completely statutorily independent and operating as a full organisation, and these annual general meetings, of which this is the second formal annual general meeting, is an opportunity for us to present to you and beyond this room, to the patients and the public that we serve, what we've done in the course of the past year. So the evening has two principal components. One is if you like, the retrospective, which is the presentation to you of our annual report and our accounts for 2014-15. The second is the prospective. What are we doing now, and what are we taking through for the next 2 or 3, 4, 5 years, which will, we hope, help to continue to improve the quality and safety and efficiency of care that we offer to the population of England. One of the most important parts of a formal AGM is that the directors of the board are held to account. And what I would wish to do tonight, by way of opening, is for me to identify each of the non-executive directors and the national directors of the board of NHS England and ask them to stand up in turn so that you can see who we are and understand what our respective roles are. I'd like to start with Ed Smith, who is the former chairman of our of our audit committee. Ed has stood down just recently in order to take on the new role of chair of the new National Health Service Improvement body, which is the merger between Monitor and TDA. Ed, would you please mind standing up? Ed Smith, ladies and gentlemen, who is moving across into a relationship which will be very close between these two organizations. David Roberts David, would you mind standing up, is a non-executive director who is also chairman of Nationwide Building Society and brings a wealth of commercial experience. Kieran Devane, former director of Macmillan Cancer Support and now the Director General of the British Council. Margaret Casely-Hayford, now chair of ActionAid and formerly legal counsel and company secretary to John Lewis Partnership. Moira Gibb, currently chair of Skills for Care, but also formerly the chief executive of Camden, London Borough Council. Victor Adebowale, the chief executive of Turning Point and member of the House of Lords. I'm just looking along to Noel Gordon in the front row, formerly head of finance and banking for Accenture. John Byrne, one of the world's, he'll be embarrassed by this, but one of the world's most distinguished scientific and clinical geneticists. So it's a very powerful board of non-executive directors. We're supported by a strong executive team. Ian Dodge, who is the director for strategy. Tim Kelsey, who is the director for patients and information. Karen Wheeler, who's director for transformation. Barbara Haken, director for operations. Jane Cummings, who is the chief nursing officer for England. Sir Bruce Keogh, who is the medical director for England, Paul Baumann, who is our finance director and from whom you will hear a little more in a moment, and Simon Stevens, who is our chief executive and from whom, again, you'll hear some more in a moment. So just to be reassured, that's our team. Not all of them will be on display on the platform tonight, but I wanted to emphasize that at the end of the formal business of the meeting, We will be remaining in the room to mingle, and please do feel free to approach any of those who I've identified, plus other members of our staff who are in the room this evening. And those who have submitted questions and we don't get around to answering formally in the course of tonight's events, we will give an undertaking. We will post those questions on the web, and we will provide answers to those questions on the web as soon as we possibly can. With that, I'm delighted to hand the floor back to you, Michelle. Thank you.
You're welcome. Thank you very much. We're going to get the Chief Executive of NHS England on stage now. And once he's on stage, he's not leaving stage until 6 o'clock and the formal proceedings are over, because there's plenty to ask him about. Simon Stevens. Simon's going to say a few words to start us off.
Thank you, Michelle. So an AGM, as Malcolm has just said, is a chance to look back, a chance to take stock, and a chance to look forward. Looking back, you can see that despite the enormous pressures across the National Health Service over the last 18 months, for the period represented by 2014-15, and over the last year since the NHS 5-year forward view was launched, there has been enormous energy unleashed at every level of the system. And we've seen, in amongst all of those well-publicised pressures, some very important progress. On our key health goals, we have, and we will be talking about these with the lead authors and key national experts shortly, set out a clear roadmap for improvement in cancer services. We will shortly be doing the same on mental health. On learning disability, we know that the NHS offer for some of the most vulnerable individuals in our country has often been lacking, and we have committed to putting that right. So at the end of next week, we will in fact be publishing a clear reprovision programme for the remaining institutional learning disability services in this country. And since the health service is a cradle-to-grave service, we are also going to be talking about the cradle in the form of the maternity task force that Julia Cumberledge and Cyril Chandler have been leading. But in the 5-year forward view, we made an argument that if we want to deliver the so-called triple aim of improved population health and higher quality individual patient care, all while being effective stewards of taxpayers' resources, then increasingly what we need is a so-called triple integration, recognising that a lot of the fragmentation and the division that has existed in this country between primary and specialist services, between physical and mental health services, and indeed between health and social care, those are increasingly irrelevant from the point of view of the people that we're all here to serve. And so part of what we've also set ourselves the task of doing over the course of the last year has been strengthening primary care with new investments in primary care infrastructure, new support for new skills, including clinical pharmacists, and an all-out effort together with GPs, national bodies, to improve the attractiveness of general practice for new doctors. This is by no means mission accomplished, but this is a clear statement of intent. We will have a chance to discuss this afternoon the work that is now underway in 50 so-called vanguards across parts of the country. Sam Jones leading that programme, Jim Mackey, probably the nation's embodiment of vanguardism, and now the highly welcome new Chief Executive of NHS Improvement, here with us this afternoon as well. And in parts of the country where, frankly, relationships have often been stressed, where the money is not working, and where care is increasingly seen as problematic, we have launched a new way of working, the so-called success regimes, in Devon and Essex and Cumbria. And I think there is a spirit of optimism in those parts of the country that people are now willing to roll up their sleeves, take some of the hard decisions, and work in new ways. But it goes without saying that the NHS is a people business, and although NHS England has limited direct responsibilities for the 1.4 million workers in the National Health Service, we believe we have to play an important part in partnership with employers, Health Education England, many other bodies, including unions and staff sides. And that, in part, means holding a mirror up to the fact that the NHS itself has not been a model employer when it comes to the health and well-being for our workforce. It means holding a mirror up to the fact that we have far too many parts of the country where we have not been a good employer when it comes to matters of race and opportunity. So you will see on your seats something that I and NHS England and colleagues across the NHS are particularly pleased to have kicked off, the introduction for the first time of a workforce race equality standard, which will chart concrete progress over the course of the next 3 years. And we know that, frankly, we've not been as good an employer as we can be for people, including people with learning disabilities, people with other needs. And so you will have a chance to hear from Leila Kogbara, the Assistant Chief Executive of Islington Council, who is working with NHS England on precisely that. So in summary, looking back over the course of the past year since the Forward View, I think we can feel good about the fact that there is energy and there is progress, but all under particularly trying circumstances. So where are we now then? So that was the past, what's the present? Well, I just want to spend a moment briefly commenting on the questions that will arise around funding and efficiency over the next 5 years. And let me say that I think we all clearly welcome the government's support for, quote, the NHS's own plan, close quotes, for the next 5 years, which of course recommended a minimum of at least £8 billion of real terms extra investment in the National Health Service by 2020. I think it's at this moment, 1 year on, just worth reminding ourselves what the NHS's own plan actually requires. And I think the way that the NHS will look at the outcome of the funding decisions that will be made on November 25th involve us thinking about 5 tests through which we will judge whether or not the spending review has delivered for the National Health Service. The first is that we are going to continue to need some front-loaded investment in service transformation to support the Vanguard rollout, investment in technology. We're going to need flexibilities in how resources are used as between both capital and revenue. Secondly, we are going to need to phase the new asks that are made of the National Health Service consistent with the phasing of the new investment to deliver on them. Thirdly, we're going to need continuing political support for the realistic but broad set of efficiencies that are going to be needed in order to deliver us the headroom to meet the demand and deliver on the opportunity over the next 5 years. And that cannot all simply be directed at NHS providers. We want a realistic and deliverable tariff efficiency for the next 5 years, and we know that we're going to have to look at other aspects of the total cost base of the National Health Service with new eyes. Those, if you like, are 3 of the 5 tests that relate pretty specifically to the NHS itself then. Front-loaded transformation support, phasing of the new asks, and support for a broad-based set of efficiencies. But the other 2 of our 5 tests, I think, relate much more broadly. The fourth would be that it's the whole care system that matters here. We will not be able to deliver the transformation that the 5-year Forward View promises unless we think about investment in workforce and we think about protection for social care services. And related to that, fifthly, we know that it's not just the whole care system, it's health, not just care. And therefore, we need all of us, including government, to make good on the public health and the prevention opportunity that we have laid out. So those are the 5 lenses through which we will assess the outcome of the spending review. In turn, we, the NHS, have got a huge job of work, which in my assessment people are entirely up for. And that therefore brings me to, if we've talked about the past, we've talked about the present, up to November 25th, what the next phase, the future, will look like. We have got to, and by we, I mean here the new NHS improvement under Ed and Jim's leadership, working in close partnership, which I'm confident we will, with NHS England, with the Care Quality Commission, with other of the national leadership bodies. We've got to now, in a very practical, sleeves rolled up way, square 3 circles over the next several months. We need to make clear to our NHS and local government partners the work that's got to get done for 16-17. So we have a realistic set of plans for 16-17, but at the same time, we also want people to be thinking out to 2020 and then reverse engineering the kind of transformational changes that are required. And we intend jointly, Jim and myself, to provide the NHS with the opportunity through next summer to get that right. That's the first circle, 16-17 versus reverse engineering the 5 years. Related to that, the second circle is that we have a national system that at the moment principally looks at the performance of individual organisations, and yet we know that increasingly we want to look at the offer that place-based whole systems working provides over the course of that 5-year period to resident populations. And the third circle to be squared is between sustaining the local energy which we have genuinely managed to unleash through the Vanguard programme with the changed behaviours, the aligned leadership that we need nationally. I'm confident that those 3 circles are squareable, but that's the task before us over the next several months. So we now have an opportunity in much more detail to get into the conversation with a number of the national leaders and frontline experts who are driving change on health and on care redesign. And as we do that, I would just finally like to close on behalf of the executive team of NHS England with our shared thanks to the non-executives, particularly to Malcolm Grant, but all of the non-execs for their leadership and their support for all of us over the course of the last year. And of course, a particular thanks to Ed Smith for taking on these important new responsibilities, which again, in conjunction with Jim, I think provide the opportunity for a real new sense of shared national direction in the years to come. Thanks very much.
So could I then ask Jim Mackey, Arvind Madan and Sam Jones to all come and join us on stage where we talk about the how the care of the future is going to be delivered. 2 of you, Jim and Arvind, have just been appointed to brand new roles. Sam has been working on the Vanguards for some time. Jim, Chief Executive of NHS Improvement, you're going to be the first person in that role. Now, I know you don't start till next month? Till November. So it's not long till you get into that role. What is it going to involve? What is your remit going to be, and what do you want to do with it?
Well, I think as Simon's already said, we've got a bit of a job about just stabilising and getting things in order into next year, and then helping health communities to think about what the future is. And a big part of that is just getting back to basics about improvement and stuff. So there'll be a process through the planning process where we'll put a framework in place that will give people a chance again to manage the money and basic performance. And I think at the moment that's crowding out a lot of the long-term sustainability and quality improvements that we need to make. So going back to the forward view, as Simon said, next summer, next spring, really helping local systems to think about where they want to be in 10, 15, 20 years'
and
time.
And in terms of the local systems, your present role in Northumbria as Chief Executive of the Healthcare Foundation Trust there, how much is that going to inform what you now try and do on the sort of pan-England stage?
Yeah. So some of the things we've done in Northumbria, I think, are replicatable, but others won't be. And I think what we need to do is across the country, there's fantastic things happening all across the country. I think a big part of our job is helping connect that to people. It's actually quite hard to see what people are doing.
Give an example of something you've done in Northumbria that you'd love to see everywhere.
A specific thing would be we opened a new emergency care hospital in June, which has transformed care, delivered 7-day services, more consistent consultant presence, which has improved quality, it's improved patient experience, it's actually also improved the financial position of the local system. So that isn't entirely replicatable elsewhere, but the core principles can be. And also I think our integration between health and social care is absolutely required across the country. And there'll be different ways of doing that, but I don't think anyone really argues with the need for better integration. It's more about how.
Well, let me turn to Arvind and particularly talk about the integration there between primary care, which is what you'll be responsible for as the new Director of Primary Care, and secondary care. how do you plan to approach your role?
So I'm coming from a background of 20 years as a GP in an organisation in London where we run a number of practices. And the interesting lessons that we've learnt in terms of scaling up some of the benefits of working across a number of practices, I think are lessons that can be learnt from in other organisations that are emerging, such as federations and MCPs and PACs. I think there are lots of challenges in the system at the moment, but equally lots of opportunities around workforce planning, the use of skill mix, how we reset the imbalance of recruitment issues in certain aspects of primary care.
Particularly in certain aspects, in certain parts of the country.
Yes, indeed.
Which people might say, as a London GP, perhaps you haven't, experienced as much as people might have seen elsewhere.
I'm not sure London practices would agree with that. I think we're as challenged.
I mean, in terms of recruitment.
Yes,
yeah.
Indeed. I think there's opportunities around integration and learning from the best of what's going on around the country from MCPs and organisations such as that, and actually the possibility of building a blueprint or a model from which we can learn and encourage fast followers to join and create the critical mass of movement that we need to address the scale of the issues. I think there are benefits to be brought to the table around a revision to the operating model of general practice and primary care, and the use of technology within that. And I think there may be work to be done around alignment of incentives within the system. But I think one of the key things that I would say is actually we are not yet tapped into the potential of patients being empowered and managing demand in partnership with them.
All right, well, I'm sure we'll talk more about that later on because it's an intriguing idea. Sam, the vanguards, I know there are many of them working many different areas. What are the most promising aspects that you want to highlight?
So I think it's interesting that Simon talked about unleashing the excitement, and over 400 health and social care systems applied to be vanguards, and 50 of them are taking forward the care models in practice. And what's interesting through all of the vanguards, whether it's in Cumbria, having a different conversation with the local communities, getting to hard-to-reach groups, designing it differently, whether it's the Isle of Wight on an integrated teams working around individuals and supporting them in practice. What's coming through from all of the vanguards is a different type of relationship and conversation with the population that's served. And unanimously across, our job is to support that happening, whether it's in Northumbria and learning the lessons for Northumbria, working with individuals and making it happen. And there are many examples up and down the country that that's already happening through the vanguards and also wider than just the vanguards.
Explain what you mean by a different kind of conversation with the patient.
So rather than being done to, it's being done with. So we have local patients, we have local citizens actually designing those services in practice. So Dudley, as represented here as one of our vanguards, has some fantastic examples of young people and adolescents designing the services that they are going to be using in the future. Tower Hamlets doing the same thing.
When you say designing services, I'm sorry, do you mean, I'd like my GP to be open,
yes.
that sort of thing?
Yes.
What else?
Making it so that it's real for the people who use the services, whether it's people being supported at home, so 89-year-olds people being supported at home as long as they want to be, in a way that makes them feel safe, or through teenagers providing and designing the services themselves. What's important, though, is the focus across the whole of the system working together, not individual institutions, and that's happening.
All right, well, perhaps we can turn. I'm going to open up the floor to questions now, but David Hegarty, if we get, where are our microphones actually in the room? If we could get one to the, David, perhaps you could talk about whether, from your perspective of what's happening in Dudley. I should explain, you're a GP and you're the chairman of the Dudley Clinical Commissioning Group.
Yes, thank you. Well, I agree with just about everything that people are saying. We're talking about whole care systems and understanding really what the population needs by engaging with them. Samantha was talking about how we engage with young people. We did it last year, we'll be doing it again in a few weeks' time, bringing children from all over Dudley together. And not making assumptions about what they genuinely believe that they want, then how you can try and make that happen for them. But we also have to understand that there is a significant way to go, and the roles that we've heard from Jim in particular, how I think the phrase used was the alignment of the incentives, and how we understand what is existing in the system at the moment that disincentivizes organisations within health, social care, the third sector coming together to make a real difference for the population. So how we can actually turn that around.
Yeah. Thank you, Simon. It all makes perfect sense, but of
Let's
course,
stop there then.
well,
Okay,
well,
we're done.
if only.
That concludes this
If
evening's
only,
AGM.
but I mean, look, the latest that we have today is that junior doctors are going to vote for be balloted for strike action. There are obviously so many manpower challenges that you have in the NHS. So I'm wondering about the extent to which you can get your workforce behind you at a time like this when their own pay and conditions are so much in the news.
Well, I think we've got two things going on. One is that real sense of intense pressure right now, and anybody who denies that is kind of away with the fairies. And on the other hand, also a pretty broad agreement that a lot of what needs to change about the system to enable it to work better for patients and indeed for staff themselves is the kind of direction of travel we talked about. So it's kind of having both those truths in our mind at the same time and charting a course from where we are now without denying all of the pressures that exist to where people can see better is possible. And that's actually what Arvind has done. It's what's happening in Dudley. It's what's happening in many other parts of the country. We've got to get there quite quickly because people's pressure and pain is now.
Okay, let's, if you could raise your hand if you've got a question, and we will get some microphones around the room. So could we get a microphone to the gentleman there and to the lady there, and we'll try and take a few. If anyone else has a question, if you raise your hand, then we'll get the microphone to you next. Yes, Sam.
Hi, my name's Bren McInerney. I just volunteer in a social enterprise in Gloucester. It's a question for Sam, really. Well, 2 points, really. Is good on you for your leadership that you're showing on this, really. It's so important. The bit I'd like to ask the question on, really, with all the Vanguard sites and new care models, what do you feel the impact on the health and social inequalities will be from all that programme, really, in terms of significant demonstrated impact for people in communities by next year?
Okay, thank you. And could we we'll come to you in a second for that, Sam. Yes, the lady
Hello,
there.
yes. My name's Nina Pearson. I'm GP and chair of Luton CCG, and mine's about inequalities as well, actually. And it's about the inequality in funding in order to commission service and for the social care package in different areas, and how that is going to be addressed in terms of provision for local populations. We are underfunded, both social care and for commissioning, and the direction of travel is not fast enough as far as we're concerned. So I'd like to hear how you intend to address that and the needy populations, really.
Thank you. And I see that there was a question submitted in advance from Harold Braun. Harold, are you here? Because there was... Sorry, I can't see a handout. But also, Sam, the reason I mentioned it is because it's similar to what the gentleman there said about the Vanguards, and particularly how you are measuring progress and success in that. So perhaps you could start with those 2 points relating directly to the Vanguards.
Thank you. So the Vanguards have to deliver revised care models that deliver against the triple aim that Simon articulated. So prevention, health inequality, and also the additional efficiency requirements. So the answer to that question is we're not measuring the Vanguards. The Vanguards are measuring themselves against those areas. In the next couple of months, we'll be publishing the outcomes and the metrics that the Vanguards have designed, including those areas for national replicability, such as emergency admissions or across the population, and including where inequality takes place. So that's being designed by the Vanguards, with the Vanguards, and being published in the next couple of months.
And is there a certain sort of proportionate reduction in health inequality that you are looking for as a gold standard?
So we're not setting a target for that.
And obviously, the target is no health inequality, but
every Vanguard has to be able to demonstrate improvements against the triple aims, designed against
but
where
is
they
any
start
improvement
locally.
good enough?
Well, it comes down to where we have innovation happening in practice. If we start with the principle that they have to deliver an X%, that doesn't work in practice. Each of the vanguards has to be able to demonstrate how they're delivering against those improvements that they've articulated and we're supporting.
Simon.
Yeah, so just on the question from the CCG about the rate of getting to fairer funding. This year we're in, 15-16, NHS England was able to halve the number of CCGs who were more than 5% below their fair share of the money, from 34 to 17, and the board's ambition is to be able to finish that job off next year in 16-17. Alongside that, we're also trying to ensure that we have fairness by bringing together the CCG commission services, the primary care, the specialised commission, and think about a place-based approach to fair shares. Doing that may then mean that that sets us on a further journey to narrow those gaps, but that I think is something the board is committed to, and the board will be making the allocations for 16-17 and potentially indicatively then for the next 3 or 4 years after that on December 17th. And that will be one of the key considerations in that decision process, which will be debated publicly and seen transparently.
Just on the subject of, you talked about the integration of the NHS and social care. The idea that was put forward this morning in the Carter report on efficiency, the idea that the NHS should be, funding at least temporary care homes in order to help get people discharged from hospital. I wonder whether you, Simon, and you, Jim, think that those are worth investing in.
Well, I mean, I'll be slightly controversial on that in that I think that the reason for the pressures in the care home sector is not principally a real estate problem. It is principally funding, workforce, and the way different parts of the system connect. So is there a case for more intermediate care, better connectivity between hospital, community health service, social care? Yes, there is. Might, at the margin, that be an idea that some places might want to explore? Yes, but by itself, let's not kid ourselves, that's not going to solve the social care pressures that rightly were identified today by Age UK and by the King's Fund.
Right, but Jim, the point being, I think the point that Lord Carter was trying to make is that it helps, hopefully would help free up beds in hospitals.
Yeah, so I agree with all of what Simon just said. We need to look at each individual health community, all of the money, all of the resource, all of the capacity, including the people, and try and make the best value decisions. So in some places that might be the answer. It's not as simple as saying it's a single answer everywhere. It might be an answer for local trusts to go into nursing home provision at some point in the future. But that needs to be tailored by their own local circumstances, doesn't it? And you've got to look at how flow works and how capacity works right across the system rather than just isolated pockets of it.
Could we turn to the gentleman there? And while he's speaking, if we could get the second microphone to the gentleman there, and then we'll come to you.
Collie Raja, I'm Head of Policy at Macmillan Cancer Support. Just picking up on the point, Simon, about front-loading investment in the vanguards, I think, which is really, really important. One of the things I think the system has kind of stripped out is the local improvement capability. And I think that there's an issue about once you've proved something works, you need that capability to spread and sustain the good models of practice. And, we're thinking obviously very much from a cancer lens, and there's the cancer strategy talks about reforming follow-up. That really needs an investment of local improvement capability. The strategic clinical networks just don't have the capacity, the capability to do that. A lot of the CCGs and CSUs are kind of very, very limited in their ability to do real transformational change. So I'd be really interested to hear what you think about just kind of building that capability to spread what works in the system.
Okay, thank you. So one question, sorry, I'm just going to take a few before we, yes, gentleman there, and then can we get the microphone to the lady here, please?
Hi,
yes.
Simon. Peter Pinfield, Health Watch Worcestershire, but I'm actually here as a patient and a long-term condition person, and I just wanted to emphasise the past 12 months, the 5-year forward view panel was the right journey. I've got to say that we're all half full people, very positive about it. But it's the movement, the patient direction for the next 12 months we're quite obviously keen to sort of up the game on, Simon, if possible. And I think I'd make a plea to everybody. I'm not a professional, I'm just an ordinary person representing my community. There is a vast amount of untapped knowledge, experience, passion out there, patients and users in the services. The way we go forward in the next 12 months is to tap and use and involve us in that, and we'll start changing the face of this country's health and services.
Okay, thank you. And the lady here?
Hi, mine's a bit more basic actually. I'm just again, like the other gentleman, an ordinary patient from Brent. I've got real worries about this business of integrated care because in the reality, particularly in my borough, the local authority funding is virtually down to they're only going to be able to provide compulsory adult social care services and won't have any more money for anything else. So I suppose my concern is when you integrate NHS and social care, NHS allegedly free at point of use, social care predominantly funded, how are you really going to be able to deal with this for integrated care? And if I may just ask one supplemental question, because it only came in this morning, my GPs are on an APMS contract, which my own patient group fought very hard to get over the course of 9 years. They got it under right to request. And all the patients this morning, a day after the meeting was called, NHSE declared that they were being tendered out. And so we're now facing, now in London, as Dr. Maiden said, there is a GP shortage. So what is NHS England doing spending resources on tendering out GP practices which are well loved?
Thank you very much. Simon.
Okay, could I just ask which borough are you in? Brent, yeah, okay. So, I mean, Brent, Enfield, a number of those boroughs have got high population growth, and so we clearly actually need a big expansion in GP capability and resourcing. I don't know the particularities of the practice question that you raised. We'll certainly look at that, and we will specifically come back to you. We do need a fair process. Obviously, when a particular contract expires, we need a fair process for looking at that. But more generally, frankly, we don't see that as being the principal way in which we are going to drive the expansion and the modernisation of primary care. Instead, what we are really seeking to stimulate are more primary care at scale with a new voluntary GP contract to be developed with GPs by April 2017, so that the kind of things that Arvind and in fact many other practices around this country, Birmingham, Manchester, many other, not just cities but also towns and counties are doing, is working out how do you keep the strength of general practice, which is its personal relationship, its population list, but also get some of the benefits of bigger multidisciplinary team working, the ability to use technology and so on. So that's the vision. It sounds like that's the sort of thing that we need to build upon in Brent. You asked a related question, which is when you put together health and social care funding, how do we make sure that we preserve the very important principle that NHS care should be free at the point of need and based on patients' requirements, not their ability to pay. All I would say is that there are many parts of the country that have figured this out. It can be done. If you go to, say, Plymouth, you will see that there the Plymouth local authority, the Plymouth CCG, using long-standing powers introduced by the last Labour government in 2006, have found a way of blending the budgets and indeed blending the care delivery without giving rise to the problem that you rightly highlight we need to be careful about. On the question about the improvement capability, I mean, I really just sort of deflect that in two ways, I think. For cancer, I'll deflect that to Callie Palmer, who will be up here talking shortly about how she's going to do exactly what Macmillan continues very effectively to argue for. And on the need for something, an NHS improvement function, I think we should perhaps turn to the man in charge of NHS improvement.
Thanks for that, Simon. I think the two gentlemen over here really summarised what we've got to do. So there's great passion with patients and citizens to change the service. We've got to harness that. If there's a lack of capacity to improve things, we need to use our collective capacity as best we can and not be precious about whether that's in primary care, secondary care, social care or whatever. And that's a mix of building some national specialist capability, but definitely building regional specialist capability to support good ideas on the ground. And in Northumbria, I have this thing, no improvement's too big or too small. And I think a lot of people rule improvements out as being, that's not worth it. It's just a very small thing. Actually, all these things count. They all add up. So find methodologies that support people to turn things into action. And if in doubt, have a go. I think that's, we'll be really pushing that. We'll try and support it.
Right. Arvind, I want to go back to what Simon was saying specifically about GPs. So there's a voluntary new contract on offer. What happens if not enough GPs want to take it up? Where does that leave your plans?
Given that I'm starting in December, I probably shouldn't be drawn too far on this until I understand all the detail. However, I think what is being discussed is the fact that actually there seems to be an ambition to move from time-limited contractual models which are through potentially procurement law and the like being bounced back into the marketplace for reprocurement in a way that is rather mechanical, and a move towards a new model of contracting which is population-based across collective groups of GPs to make more impact in the system. And it's to be encouraged that there's a willingness to explore new models in that way.
Okay. Thank you. Yes, question. Jen, have you got the microphone already? If you could raise your hand. And lovely. There's one on your other side. Great. And sorry, if other people could raise it. And we'll come to you next. Did you have a question as well? Oh, okay, right. Right, and then we'll come to you next. Go ahead.
Right. Afternoon, everyone. First point I wanted to make actually is that anybody that's not working for the NHS and see themselves as a patient, anybody in the NHS serves you, so you're actually the most important people in the room. Just want to highlight that. So anyway, my name is Dr. Giles Morris, and I work for the Health Innovation Network, one of the academic health science networks for South London. I actually left work in clinical practice. I did that for 3 years. Now I'm in user experience, looking at user-centered design, specifically in the way we deal with technology. So any talk about us supporting our involvement of digital and technological innovations in healthcare is right up my street. That's what I do now. But crucially, what are we doing to get more doctors involved with this as a formal process that isn't them being a clinical fellow, academic fellow, some other sort of fellow? Them actually having it as part of training somehow. So there's actually a workforce of doctors who are IT savvy and actually part of true user-centered design of IT innovations.
All right. So in your experience, are there very few doctors who are IT savvy enough to play a role, or are they just not being used?
To explain my situation quickly, because I know we're pressed for time.
Would be good.
I've had CCIOs tell me they didn't know they could tell doctors to go into IT. I've had virtually no support, like formal support from any clinician or careers advisor to go into IT. I had to do it off just faith.
Okay. Okay, thank you. And gentlemen there, if we could pass the microphone across. Sorry, if you could raise your hand until it comes to you, because otherwise we... Thank you.
My name's Owen O'Donoghue. I'm a volunteer for Brighton and Sussex Healthcare Trust. And I wanted to ask the panel about what they think the role of volunteers will be in this 5-year forward view. Because for me as a volunteer, I was on a volunteer waiting list for 6 months to actually volunteer in the NHS. And I wondered, is there a place that could be faster?
No one took you up on your offer?
I was on offer, but I was on a waiting list for 6 months.
Okay, right. Is that, Sam, how typical is that?
So in practice, both within the Vanguards and outside of the Vanguards, we have volunteers and carers shaping the future. And just go back to the points that were made earlier on, absolutely agree with our colleagues from Worcestershire. We've talked about it previously, unleashing and supporting carers, volunteers, people, the unsung heroes in practice. So up and down the country in the Vanguards, that is already happening, but not just in the Vanguards. And there's so many examples that, and certainly understanding from Brighton and Sussex perspective, how we can share the best practice that's already happening.
Okay, so people shouldn't be on waiting lists for waiting to help.
So we've got about 3 million people who are giving their time freely as volunteers in some way connected with health or social care. There is something rather bizarre about being on a waiting list. The NHS does waiting lists, but why we should have to do a waiting list for volunteering is kind of another matter altogether. So I think one of the conversations we've been having with a national group of organisations who marshal the engagement, because finding support for people who want to volunteer is a professional activity in its own right, as it were. It doesn't just happen by accident. A lot of the volunteering effort has been linked to hospitals, which is desirable and great, but actually a lot of the further opportunities we have might not be in hospitals at all. So think about Yorkshire Ambulance, first responder schemes, think about some parts of the southwest with heavy volunteering opportunities with individual long-term users. Think about the work that Red Cross has done with volunteers looking in on people discharged from hospital when they go home, just to see that they are doing all right, to reduce the likelihood they end up then being readmitted back to hospital. There are myriad opportunities here. So come nobble me afterwards, and I'll put you personally in touch with some of the people nationally who are trying to figure this out. And your experience, I think, would be very illustrative of what we've got to get sorted.
And the point about not about doctors and technology. I mean, not enough has generally been spent on technology in the NHS over a period of time. Would that be fair?
So in our model of care, we've used technology, and one of the very enlightening things I found during the process of doing that work was that actually, I think probably before that point, my involvement of patients in pathway design was largely lip service. And the ability to actually understand using measurable tools and metrics on how, for example, patients navigate websites brought a whole new enlightenment to my thinking on actually how you can design services to create a win-win for both patients and clinicians if the system is designed intelligently. So actually the trick is to sit within that fertile territory of creating a win for patients and a win for organizations providing that care, and make the patient's preferred way to access the system the one that makes us most efficient in providing that care as well.
Sam, we're nearly out of time in this section, but is there a vanguard, a part of the country where you can point to where, you know, doctors are harnessing all the data in a really useful way, and technologically it's really working as a model?
So Vitality in Birmingham have redesigned their services, so over 60% of...
what is Vitality?
It's
beyond what is Vitality, you know, not the word, I mean...
What is Vitality? It's a group of GPs and primary care working together, and they've redesigned their services so that over 60% of their patients no longer need to come to the surgery for their appointments, and that's by using clinicians working with patients to redesign the service, and that's happening in practice. That's
So
one
this
example.
is Skype consultation or
Skype
telephone
consultation, email consultation, actually doing it on the phone, but with GPs doing it as opposed to others, and as I say, over 60% happening in practice.
All right. Thank you very much. Of course, there is so much more we could ask you all, although I appreciate Arvind and Jim are not yet in their roles. Thank you very much. I'm going to ask Simon to stay on stage. Thank you, Arvind, Sam and Jim. Thank you very much. And if you did have specific questions for any of them, they, you know, all the NHS leaders will be around after 6 o'clock, so I think you can feel free to put your question directly to them. Now, the finances. I'd like to invite Paul Bowman up to give us the figures.
So when you go to the theatre, the interval is the opportunity to go and grab an ice cream and a glass of wine. At least it is when I go, anyway. This being the NHS England AGM, of course, that would be a rather unhealthy thing to offer you in the brief pause between the two entertaining parts of the evening. So instead, you've got the Finance Director talking to you about this, which is the annual report and accounts for the commissioning sector of the NHS. I'm sure most of you will have eagerly scoured it from cover to cover. I rather romantically hope that you stopped particularly on page 119 and slowed down at that point where the numbers begin, but I suspect that, like most readers, you will have been much more captivated by the most important parts of it, the bulk of the 212 pages or so that we've written, which is dedicated to the many and varied ways in which we're changing the lives of patients. And that, of course, is the theme of the bits which I'm rather neatly sandwiched between. However, this being an AGM, we do need to dwell for just a few minutes on the accounts, partly as a historical record, but perhaps more particularly to see what they tell us about the future. There they are. Last year, I described the task of maintaining financial control in our first year as a Herculean effort. Well, 14-15 has seen the maturing of that financial environment, enabling us to run a rather more orderly year-end process, delivered to a significantly accelerated timescale, and maintaining our clean sweep of positive audit opinions. The NAO, the National Audit Office, not, I have to say, a body known for its spontaneous and lavish compliments, described this year as a major achievement for such a large and complex organisation. And before I go on to the content, I would just like to pay tribute to the CCG, CSU, and NHS England teams around the country who've made this possible. But what of the financial performance that it reports? I'm pleased to say that as in 13-14, the last financial year I reported in, we met all of our financial performance targets across the complex array of measures on which we're held to account. See page 178 for details, or indeed if you're particularly excited by the technicalities, do come and join my team. We have a few vacancies. Oops, that wasn't meant to happen. There we go. Yes. Just as importantly, though, we responded to the Department of Health's request to defer discretionary investments towards the end of the year last year to compensate for the well-publicised cost growth issues in the provider sector, and thus enable the health group overall to stay within its spending limit, even if only by the slenderest of margins, as some of you will have seen reported. So turning to the actual numbers, you can see that the commissioning system showed a small underspend of 0.3% against our main financial limit, which accounts for about 99% of our expenditure. This is well within the forecast range that we'd been predicting for much of the year, and I have to say constitutes something of a point landing in a year when the strain started to tell across the system. Picking up briefly the three main components within this performance, clinical commissioning groups ended the year with a small underspend of 182 million, also equivalent to about 0.3% of their allocation. We do need to be a bit cautious in interpreting this, though, for three reasons. Firstly, it reflects in part the investment rephasing I mentioned earlier, which in turn increases the pressure on expenditure in the current year. Second, it's flattered by a number of specific items, particularly in terms of reduced spending on the continuing healthcare claims, which were inherited from the PCTs. And thirdly, perhaps most importantly, there is still quite a bit of variation in individual CCG performance. So while the vast majority of CCGs delivered their financial plans and live within their means, 19 CCGs ended the year in cumulative deficit, having clocked up a total of 213 million of in-year deficit between them, just over half of which was unplanned. Now, in part, those deficits reflect individual CCG allocations, which are significantly below their fair share budget, which is why we significantly accelerated the pace of change in our decisions on allocations last December, as Simon rather annoyingly has already mentioned. But part of the problem is a steady stream of individual organisational performance issues, which led us this year to develop and roll out an extensive toolkit and process to prevent, detect, and then rapidly intervene where necessary in emerging problems. Direct commissioning ended the year with a slight underspend of 0.1%. The grip on cost and activity in specialised commissioning has strengthened considerably over the last year, but there have been new pressures in the form of the rapid growth of the Cancer Drugs Fund and the appearance on the horizon of a considerable volume of exciting but extremely expensive new drugs across the clinical spectrum. So while this year we were able to cover the impact of these pressures with operational underspends in other areas, we are having in 15-16 to exercise even tighter controls to ensure that our planned growth of investment in strategic areas like primary care is not compromised. And finally, NHS England's running and central programme costs were underspent by 172 million, largely as a result of a rigorous internal review to drive out savings and prepare for the much tighter spending limits in these areas in the current year. I said last year that we were engaged in a financial marathon which will test our resilience to the full. Not a particularly insightful prophecy, I guess. Well, the good news is that we've survived the first few miles. But it's pretty clear from the underlying trends visible in 14-15 that I've just been describing and the modelling work that we've done for the future that the remaining distance is going to be even tougher, with the first major uphill stretch already with us in 15-16. On the provider side, it now seems inevitable that the deficit will be significantly higher than the 800 million or so reported last year, underlining the importance of the measures currently being adopted to control the burgeoning agency spend, which accounts for much of the financial pressure in the provider sector. But it's important to remember that the commissioning side faces significant challenges too. Our plans for financial balance this year have again required the deployment of significant amounts of historic reserves, 582 million to be precise this year, partly to fund investments in transformation of the type you've been hearing, which I think is a good thing, but also to cover the in-year deficits of about 20 challenged CCGs whose return to break-even can't be completed this year. We are, of course, completely committed to bringing the overall commissioner position in on break-even at the very least, but halfway through the year I have to report the balance position is looking distinctly fragile. I guess it's no great surprise that 15-16 is a tough year. The combined operational deficits are easily explained by just two factors. Firstly, as I've mentioned, the dramatic and increasing provider overspend on agency and temporary staffing. And secondly, the £1 billion of net transfer from CCGs to local authorities in the form of the BCF. So the obvious question, it's easy to analyse why it's happened, the obvious question is, can we complete the next leg of the marathon without stumbling? If commissioners, providers and regulators pull together, nationally and in every single health economy around the country, it is still just about possible to make the sums work overall in 1516. But it's going to take all the discipline, the determination and the creativity, and here I must stress I mean creativity of the non-accounting variety, that's what we're going to need if we're going to survive this particular test of our uphill running. There are, of course, good reasons for optimism as we look forward. We've got a plan in the form of the Forward View. We've got a firm commitment from government to fund the plan, starting with the 2 billion extra we received in 1516 and continuing the promised real terms growth funding of at least 8 billion over the next 5 years. Simon's comments on the phasing of that are clearly salient in that context. And finally, we're mobilising across the NHS to deliver the annual efficiencies needed to give us the headroom to manage the extra demand we'll face over the coming years. Every single part of the system has got a role to play in this, from providers focused on clinical productivity and procurement to commissioners leading the charge for maximum value from every pound spent, by rapidly rolling out the Right Care programme, which I hope many of you will have heard about and started to see in action, by implementing new models of care in the vanguards and of course beyond, and also by liberating the power of patients themselves through major initiatives on prevention and self-care. And there's also a significant contribution from pay restraint and reduced spending on central functions. So it can be done, but I hope this rapid canter in every respect through the financial challenges of the sector, past, present and future, has demonstrated the urgency of the task. Delivering this year is essential, but it's only the start. Delivering in future years will keep us ahead of the funding curve and enable us to invest to build the momentum we all want to see behind the Forward View. Thank you.
Thank you, Paul. Thank you very much. Thank you. Just before I invite the next panelist on stage, Simon, I want to ask you to comment directly on what Paul just said, because he's talking about, well, naturally, he's in charge of the finances. But, you know, when we talk about this firm commitment from the government in terms of funding, the way that you talked about how you're going to scrutinise, you know, what happens in November with the spending review, it didn't sound as if you were that confident that what you need and what has been promised is going to be there.
I don't think you can draw that inference.
Well, you I mean, but the way that you talked about all the different measures at which you're going to look at everything that comes out of that
it was
spending
simply to
review
remind us all that when a year ago in the Forward View we said a minimum 8 billion, that there were some 5 related aspects to that which we need to get right. And I detect great willingness to understand and move in that direction on a shared basis. And that's what we'll be looking for.
Okay, and will that money, that £8 billion figure, cover what you have in mind for the future, or is it covering what the day-to-day needs of the NHS now?
Well, it's a combination. We want an NHS that is bigger and better, but therefore an NHS that in some respects is going to have to be different. And how's it going to have to be different? The next panel's about to tell us, Michelle. It's going to have to be different in mental health. Okay. It's going to have different in cancer. It's going to have to be different in the way that we employ people who need to interact with the health service itself. And when you get to talk now to the team that are about to join us on stage, you will see the fire in the belly for improvement that we require. You're very keen to get them on stage,
and that is fair enough, because there are 4 very important areas that we want to talk about. So I'm going to ask them all to take their seats as I introduce them. Very pleased to have you all with us. Paul Farmer is the Chief Executive of Mind, the mental health charity, and Chair of the Mental Health Task Force, which is about to report very soon. Callie Palmer is the Chief Executive of the Royal Marsden Hospital. She's just been appointed NHS National Cancer Director, and she's going to lead the implementation of the 5-year plan to improve cancer care. Chris Askew is the Chief Executive of Diabetes UK, and Leila Kogbara is the Director of the Learning Disabilities Employment Programme at NHS England. Paul, why don't we start with you, because I think we're a few weeks away from the publication of your report. Give us a sense of the direction of travel. I'm not asking for the headlines now, but...
Well, far be it for me to reveal all at this particular event, but I suppose our starting point has been to listen to what people with mental health problems, their families, and mental health professionals and the wider public want to see from mental health services in general. And around the time of the election, 20,000 people responded to our online and paper-based consultation. So we've got a very clear view from people with their own experiences about what they want to see. and they align into kind of four really major themes for us. The first one is around prevention, about how do we help and support people to get the right kind of support at the right kind of time, and to be able to prevent mental health problems happening in the first place. Secondly, around access, likely to be a very key part of our recommendations. We know that there are good quality treatments available and support for people, but excuse me, for too many people, they're not available everywhere, and that aligns with what you've already heard from Simon and others. Thirdly, integration. So we operate in this world where quite often mental health and physical health seem to operate in these kind of twin tracks. So how can we ensure that in that place-based approach, mental health is a key part of what happens? And we're already seeing great examples of this in the Vanguard program. And finally, quality, so that people believe and feel that the experience that they receive from mental health services is transparent and visible to all. So those are our kind of emerging themes, and I think the gain here is to really give people who experience mental health problems a real chance to not just have a good experience of mental health services, but of course much more importantly than that, to be able to achieve the kind of outcomes that they want. So on the whole, people tell us they don't really want to spend very much time in the NHS. They want to get out there and get on with their lives, find a job, have decent housing, have good quality relationships.
Okay, and thank you. And I should underline that the reason that these 4 areas have been chosen is an acknowledgement that these areas where outcomes or performance of the NHS haven't been good enough. So from mental health, let's turn to obesity and to Chris Askew. And I know that's only part of what you do at Diabetes UK, but it seems to me that there's a real momentum now building around particularly campaigning on sugar.
Yeah, I think that's absolutely right. And of course, it's of key interest to us in diabetes. We have 3 million people in the population with diabetes. That's twice the level of incidence that we had 20 years ago. We know the main modifiable risk factor is being overweight, being obese. 62% of the population are overweight or obese. 90% of people with type 2 diabetes are overweight or obese. We have a significant challenge coming towards us on this, and that is why we're able, I think you say things that aren't going well. One thing we're able to applaud and acknowledge is the National Type 2 Diabetes Prevention Programme, which is an activity at real scale, at real pace, which is drawing into its vortex of energy a lot of insights, a lot of activity, and we will get a chance to roll that out very rapidly and understand what role that has to play in a major public health activity. While I've got the mic, I'm going to move on for that and say, of course, prevention is important, but there's much we need to do as well for those very many people that have type 1 and type 2 in terms of preventing onward complications. Back to the Future is in the news today. On the same day, the National Audit Office have published their update on progress on improving diabetes services. And there is some depressing circularity of going back to the future in that report. Yes, we've made some progress in some key areas. We've managed to bring down premature mortality in type 2. But in many areas, we seem to be stuck in a cycle.
Pick one that's the most important thing that you'd want the NHS to focus on.
Yeah, absolutely. So if we look at structured education, we have an offer that's still in the teens. We have take-up that's in single figures, and that figure hasn't moved since 2012. We really have to understand how we can provide a more structured support and education. I believe there's a strong appetite amongst those I've spoken to with diabetes to have access to that structured education. But right now, at the moment, we've clearly got a problem which we're not tackling. I'm very interested to hear about where we bring users into the design of that. And clearly, if we're talking about activating patients to take a role in managing their diabetes, we're going to need to make sure that design of those education opportunities very much has their insights built into it.
Leila, give us a sense of what you are trying to do with employment opportunities within the NHS.
Okay, so the Learning Disability Employment Programme really is about trying to get the NHS itself to be a more diverse employer. Obviously, there are lots of ways in which it can be a more diverse employer, but looking at people with learning disabilities, they've got one of the lowest rates of employment across the country. Less than 7% of people with learning disabilities are employed, and yet the majority do want to be in work. So about 80% or so want to work. So the idea is that you can have a win-win for the people themselves, letting them be able to earn a living and live a fulfilling life like anybody else, and a win for the NHS in terms of not just having a diverse workforce that really can deliver better results for patients. And, you know, the NHS, the 5-year forward view talks about the need to employ people with learning disabilities in the kind of roles that would have made it less likely, that would have made Winterbourne View less likely to happen, for example. So thinking about how people, the fact of being diverse makes us think about the people who we are serving. And that's a really key, important point. So
what stage is the programme at?
So where we're at, we've launched guidance, which is on the NHS Employers website. This is jointly with NHS Employers and others. We have launched a pledge. So if the pledge spikes tomorrow morning, that would be a good indicator for the success of this conference. So if you go on NHS Employers, you can pledge. There are 3-stage pledges. The first stage is just to say, I'm up for it. That's all you have to do to sign up to start with. And then you kind of try and do something. And then, so there's guidance, there's a pledge. And then NHS England itself has employed some people with learning disabilities to do jobs, for example, in the patient and the public engagement team. And we've got good examples across the country of some places, some hospitals doing brilliant things where people with learning disabilities are employed in laboratories, getting fantastic results.
Have you got a target number in mind?
We haven't set a target, and there's something we need to think about whether we eventually do, but the idea is that we try to get, there's some good practice, try and get uniform, getting better, but we haven't got enough of a good baseline at the moment to know exactly where we are. So there's some data challenges about the employment statistics in the NHS.
Callie Palmer, very big job ahead for you in leading the implementation of the plan to improve cancer care. How are you going to do it? That's the million-dollar question.
Yeah. Well, the good news is we have a roadmap because the Independent Cancer Task Force published recommendations. There are over 90. So one of my jobs is to ensure that we make progress on some early priorities. And we know there's much to be proud of in the delivery of cancer care in this country. The majority of patients say that their care is very good or excellent. We're closing the survival gap between England and the best countries in Europe and elsewhere. But we also know there's a lot more to do. And the ambition is set, the roadmap is set, to try and save, to ensure that 30,000 more patients, more people survive for 10 years or more by 2020. And one of the big tasks for me and the team that I work with is to make sure we shift resource from late-stage disease to prevention, early diagnosis and early-stage treatment.
Early-stage diagnosis being, I suppose, the holy grail, if there is one after prevention.
Yeah.
Because people say their care is good once they are in the system.
Yeah. Patients, I've been at the Royal Marsden for a long time. I've talked to cancer patients over the years, and what they say is their care is not seamless. There's a lot more to do to integrate it across care boundaries between hospital, community and home. And they also feel that when they're in a hospital, they're protected, they're safe, but we need to make it safe for them to work across the whole boundary and to get into the right service. So to have the right treatment in the right place first time and not to bounce around the system, which I think is an experience for too many patients today.
Yeah, and Simon, that goes back to obviously what we've been talking about in terms of integration. It's where people might fall between the gaps between primary and secondary care or indeed elsewhere in the NHS.
Yeah, it does. I mean, Callie's being typically modest in that one of the vanguards that has been kicked off relate to cancer services in 3 parts of the country, one in southwest London that has the Royal Marsden at its hub, another University College Hospital, also here in London, another up in the northwest at the Christie Hospital. And the idea there is that we blend the funding for cancer surgery, for radiotherapy, for cancer drugs, for oncology, and get the clinicians and the patients to say, here's how we want to improve outcomes over the next 3 or 4 years, and we will then just use the money to invest to do that, as against paying for every click of the turnstile on tariffs and all the rest of it. And so that is part of how we're going to enable that integration. But as Callie says, there's a big prize on offer here, which is that the Cancer Task Force estimated there are 30,000 lives that could be saved by 2020 if we get this right, of which up to 11,000 could be on the back of prevention and early diagnosis.
But on this point about how you pay for things, someone submitted a question saying, to what extent is the internal market and the NHS in England a thing of the past?
Well, I mean, that's a sort of theological question for another day.
Or maybe for the next 30 seconds at least.
Yes. Well, look, is there going to be a planning and funding function that is separate from the job of delivering care? Of course, because we know that we want to improve services, and that means sometimes taking a step back from what we've currently got and saying, here's how we want it to look differently. Now, what do you call that? Hey, that is the theological question.
Okay, all right. Would you call it the internal market? Is that term is not, is that
I don't. I call
out?
it implementing the NHS 5-year forward view.
Of course you do. Right, okay. We have the remainder of the time we're going to devote now to questions. So please raise your hands. Let's see, we'll try and get through as many different ones as we can. Great, so gentleman here and the lady there, and after that we'll come to you, sir. So can we start with this gentleman here? Okay, it's fine. No, let's start there. Okay.
Mike Smith, I'm chairman of the Patients Association. We constantly hear on our helpline that integration is the answer to a satisfactory 24/7 community care service of the kind that we don't have and haven't had perhaps for the last 12 years in the way we did before. Now we hear that more of the same is not the answer. Is anybody willing to put their head above the parapet and tell us what more of the same could bring it about? Because one constantly hears that it's so much cheaper to deliver a community service, sometimes it's said as third as much as it is a hospital service. The hospitals are bunged up with people who can't get back into the community, blocking a bed at £2,500 a week, when it might only cost £700 in a social care bed. What's stopping this? And, well, let's say, you know, the vanguards are a way forward and everybody's looking to those, and the 5-year plan seems to be a good thing. But from the patient's point of view, it seems to be going oh so slowly. Can anybody tell us, and are they willing to say, what could be done to provide that? We're not going to give you this more of the same because that doesn't work, we know. Thank you.
Thank you very much. Lady over there, and if we could get this microphone to the gentleman there.
Hello, I'm Sarah Prima, I'm Director of Strategy at the Leicester City CCG, and I'm really interested with an issue that we're grappling with at the moment in the city, which is about bowel screening. And we are grappling with how we can increase uptake, particularly within our ethnically diverse population. And within the cancer work, I was wondering whether there was going to be a place for shared knowledge, where places have tackled this question and got a good answer, and whether that was part of the cancer work that you're leading on.
Okay, thank you. Callie, before you answer that, let's just turn to this gentleman.
Good afternoon. My name's Gordon McFadden, and I am the chairman of United Amputees, which is a peer-led charity. You spoke, Chris, about the rising numbers of diabetes in this country over the last 20 years. That obviously results in a higher number of complications, in my case, amputation. Now, since the Morrison report of 2012, NHS England have been quoting 5,000 amputations in England per annum. Recently, we've heard of the 135 shoes, which is 7,000 per annum. I would suggest that we're more like, if you look at the all-party parliamentary group on vascular diseases in 2012-13, they looked at 14,000 per annum. And yet, we're still being quoted 5,000. So is our prosthetic service being wholly underfunded for the 400,000 amputees in this country?
Perhaps you could answer that first, Chris, and then I'll come to you, Callie, and then I'll ask Simon to answer the question about the pace of integration.
I'm going to profess to not have all of the answers for you on that one. It's partly to do with my time in post, and partly because that's not a piece of work we've really investigated. I'm certainly happy to come back to you on that. What I do know is that complications that lead to amputations, carry a huge cost and burden, both financially but also to individuals. And there are some relatively straightforward upstream interventions that can be helpful. I joined a day seminar earlier this week in Milton Keynes. 80 people living with type 2 diabetes who had a day hearing from the local podiatry team, a diabetes specialist nurse. We were sold out on that event, turned people away, and we did the same last year. That event cost, I think, £2,000 to stage. If we prevented one complication in terms of lower limb amputation, we would have paid for that session many, many times over, but we don't have the resources to do it. So I'm not deflecting. I don't have the answer for you on that around levels of funding, but others might.
You or someone else can
I would certainly applaud the fact that we must look at how we avoid these complications much earlier on.
Okay, thank you. Callie.
And just on bowel screening. So I said earlier, and I'll just repeat the point, that I think it's incredibly important to move the resource from late-stage treatment to prevention, screening, early diagnosis and treatment to really save those 30,000 more lives and 11,000 through improved diagnosis. I think we're making progress on screening programs, including bowel screening, but what we don't need to do is reinvent the wheel. And I think it is very important in my national role to make sure that we can share information about beneficial screening. You know, it's been one of those controversial subjects in terms of how best to do it, which tumour types, what works, what doesn't work over time. And I think it's absolutely essential that we look at it as a sort of national, in a national way, so we don't try and reinvent the wheel in local areas. And I've really enjoyed talking to colleagues in Manchester over the summer about the approach to improving cancer care nationally. You know, you could see how nationally you could roll out screening better, early diagnosis better, starting with some sort of pilot system. So it'd be good to talk to you about your experience. Thank you.
And Simon, the point from the perspective of the patients about, you know, how slow it feels that change is.
Yeah, so there are kind of two ends of the telescope here, and I think how we've got to measure whether any of the triple integration that I talked about around health and social care, and physical and mental health, and primary and specialist care, whether that's happening is from the patient end of the telescope. And so national voices and a consortium of patient organisations, and I pay tribute to the work of the Patients Association, Mike, as well, have come up with a series of so-called I statements. This is what, from the point of view of individual patients, they would be looking for to see whether integration really is or isn't working. And I think, frankly, we should be, and I think we're going to be, measuring that in the Vanguards and elsewhere to see whether, from the patient's or the consumer's point of view, it is real and whether we're getting genuine improvement. Over and above all of the kind of gubbins that goes with funding flows and teams of health professionals and joint working with local authorities.
Thank you. Okay, more questions. Yes, we go to the lady there, and who else? Someone else on this side of the room? Okay, lady there.
Hello, Deborah Arsina, Chief Executive of Bowel Cancer UK, and particularly welcome to Callie into her new role. So firstly, I absolutely agree that it's very important that we focus on shifting resource from late-stage disease into early-stage disease. And just to pick up on one comment about how we can increase bowel cancer screening uptake, the sharing of information has been appalling over recent years, and there has been an incredible amount of recreating the wheel. But the very quick win, which is in the Cancer Task Force recommendations, is the implementation of FIT screening, fecal immunochemical test. It shows about a 10% increase in uptake. Let's bring that in quickly, please. But what I really wanted to say was that whilst I agree that we must focus on early diagnosis, we must not forget the many, many cancer patients who are diagnosed late, and that actually there are some wins both in terms of prolonging and improving quality of life for people with advanced disease, but also to save lives there. For example, it is not acceptable that there is such a postcode lottery around access to liver surgery or even referral to liver surgeons within this country, and that there are bowel cancer patients and many others across other cancers who are not being reviewed by a liver surgeon and being put onto palliative care pathways, if you look at the research from Aintree. And I really wanted to ask Callie and Simon, actually, how are you going to tackle that so that we are not forgetting those who are most vulnerable and who need our help now, today?
Thank you. I mean, that is an unacceptable variation.
Yes, I absolutely agree. So, and we know those differences and variances occur, and we need to deal with those. So, although I was emphasising prevention and early diagnosis, I wouldn't wish you to feel that precludes the real focus on survival, quality of life, quality of patient experience for patients across the spectrum. It absolutely does. And I think that's incredibly important part of the work that I will be doing.
Is there a particular cancer where you look at the figures and think this one is, you know, we're doing so poorly on that, this is my number one priority?
There's, well, you have to create a balance between impact for the largest number of people with some of the commoner cancers and just making sure that with some patients with very specialised, rarer conditions, that they have access to the right specialists. So the comment I made, I borrowed it from, I think it was from Tim Briggs, of, treatment in the right place, the right time, first time, means that we need a system where those with the most specialised conditions get the right support at whatever stage they're going through the system, as well as making sure that we target some of the priorities on areas where you can make big change quickly. So you're talking about large volume impact on patients, for example, with breast cancer.
Yeah, and yet, Simon, all of that could still, you know, if you take that postcode lottery term, you could have improvements everywhere, and yet you could still have tremendous variation depending on where in the country you live.
Well, I think just sort of building on Callie's comment there, I think half of cancer deaths are 4 main cancers, and so I think the answer, the supplementary I would give is that bowel and lung are the 2 where we need to see a big improvement in early diagnosis and the consistency of treatment. Far too many people, as you know much better than me, are being diagnosed at stage 3 or stage 4. In the case of bowel cancer, that means your chances of being alive at 5 years are less than 1 in 10, compared with a 9 in 10 chance of being alive if you're diagnosed at stage 1. So we've got to track we've got to track the stage of diagnosis for each of the main tumour groups. We've got to track 1-year survival rates and hold CCGs and local health systems to account for that as proxies for the broader quality of care and the consistency that is then offered. And the Independent Cancer Task Force, as you know, and again, I know we're involved in, has a set of proposed metrics that we should be using to hold each part of the NHS to account for consistent quality of care, and that's what we need to do.
Just before I turn to our final few questions, Paul, I want to come back to you and just talk a bit more about mental health. Do you believe that we are heading towards a point where we have parity either in perception or indeed in the care that's actually delivered for mental and physical health?
Well, I think that's got to be our ambition, and we've seen a significant shift in the way the general public is thinking about mental health over the last 5 or 6 years. The visibility is higher, the awareness is higher, and with that, I think comes a pressure and a requirement to deliver on that parity kind of ambition that's set out very clearly in the 5-year full review. In some areas, the mental health system is starting from a point that is further behind other aspects of the NHS. So we have to map out what we need to do now to really lay the foundations over the next 5 years. But I think that is absolutely an achievable objective, and particularly if we can really think about the way in which we integrate. So, for example, we know that people with long-term physical health conditions can really benefit from access to psychological therapies. It saves money to the NHS, but it also improves outcomes. And one of the areas we're looking at is how we can hardwire those opportunities for people to get those kinds of care. So there's a win-win in terms of achieving benefits for individuals, but also for the system.
Okay, thank you. I think we have time for a few more questions. So again, if you raise your hands, gentleman there and gentleman there as well. Anyone else? Go ahead, sir.
My name's Victor Bolter. I'm a bowel cancer survivor. I'm on the statistics now because it's over 10 years. I believe that we are being too nice about cancer. We've got to convince people that cancer is curable, and the earlier you get it and you get it discovered, the more chance you've got of success of living on. Being a bowel cancer survivor, I ask people when they quiz me, when did you last look into the toilet bowl? And they go, why? I said, because that tells you a hell of a lot about your health. And I think we've got to look at basic things to get people more aware of cancer, and generally for the whole of the national health, more aware of all things that you can do to give yourself a better chance of reaching 100. You know, a lot of people at 20, 25 are happy to die. They don't think they will, but gradually it catches up with you. So, you know, the forms that we give people are not brutal enough. You know, if you don't go for this test, you might die sooner
that would
rather
be
than
that
later.
would be a hard message to send out. But it's an important point. Let's take this gentleman's question, then we'll come back.
Gary Jevon, Head of Pathway Development for the InHealth Group. Question for Simon is, how do you envisage the role of independent and third sector providers evolving over the next few years to support the 5-year forward view? Do you think it's of increasing or diminishing importance?
Okay, thank you. Perhaps we could just, Callie and Simon, talk about cancer for a moment and this gentleman's experience. Would you, Callie, support more alarmist health messaging?
I'd call it giving patients confidence to come in early. So I think one has to be quite careful with the messaging. I agree there's an educational role. I agree we need to get the message out there, and your experience shows that. But what I like to do is work on the basis of confidence, that if people come in early, if they get screened early or they get diagnosed early, then that can make such a huge difference. It's getting those stats and that evidence out there to give people the confidence and the courage to come and get tested, get diagnosed, get seen. And alongside that, we're looking at a sort of new fast target of 4 weeks to definitive diagnosis from GP referral. And again, I hope that will give patients confidence that they get a definitive cancer diagnosis fast, or an exclusion that they have no cancer, they're fine, or they may need some other kind of specialist support. So rather than alarmist, I understand exactly where you're coming from, but I think it's giving patients confidence and evidence about fast access to the system and how much difference that can make, so people can feel, you know, really reassured about coming into the system at the right point and quickly.
But do you think, Simon, that there is a case for adding more urgency, you know, getting it in people's ideas, you know, you really need to have this test?
Well, I think, I mean, really, I've got very little to add to what Callie said, which is that, you know, there's a whole kind of series of expertise about what is the best way of engaging people to get them to have the relevant check or to take account of their own health. There is one area, perhaps not in the cancer domain, however, where I do think, and it picks up something Chris said earlier, we are actually turning the volume up nationally and being more explicit, and that is on obesity, and I think that's a good thing. And I do think part of that is having a very straight conversation with parents about what's happening to their kids, and I think that is a very welcome development, and we need to go further.
Making fizzy drinks more expensive?
Well,
AKA the sugar tax?
Yes, I mean, I've previously said, I think you know, if retailers or the food industry are worried about the funding of the national living wage, then why don't they just stick it on the prices of the junk food and the fizzy drinks that they're attempting to sell? And I've also said that I think as parents, we should have a pretty clear no fizzy drinks policy with our kids. That's an entirely discretionary, nutritionally useless, health damaging choice that we could just choose not to make.
Gentleman's point there about
direct communication.
Yes. Yeah. The gentleman's point there about the role of independent and third sector providers, how they come into the 5-year forward view.
Well, they've obviously always been a part of the offer to NHS patients, both in terms of planned surgery, other parts of the health system, including mental health. I think, frankly, we're taking a more sophisticated look at what that should be in a whole range of areas. So in the case of the work that Paul is leading on mental health, I think, frankly, we have not been as smart as we need to be about the circumstances under which we do end up relying on distant, medium secure services that might be provided by the independent sector or by the NHS, when we could have built up local NHS and third sector services and avoided patients needing that. It's a very small part of the NHS expenditure, 6 pence on the pound. My personal prediction is that the vast majority of NHS funded care will continue to be provided by NHS providers.
Okay, thank you. Gentleman here in the second row, and was there, oh yeah. And then after that we'll come to the lady in the second row from the back, and we'll try and get a few more in if we can. A you could be brief, sir.
I will very quickly. My name's Liam Brennan. I'm president of the Royal College of Anaesthetists. I'm not speaking in that capacity, but I am the father of a son with profound learning disabilities who's now an adult. And I'm very delighted to see Layla here talking about employment opportunities. But I'd like to know what the plan is from Simon and others about improving equality of esteem and access to health service for those with learning disability. Because I've spent my whole son's life making sure that happened. And I'm articulate and can do that, but I do fear for people who can't.
Yes. So you're absolutely right. Obviously, it's a huge... Jane Cummings here, the Chief Nursing Officer, leading the work nationally on exactly that. So I'm sure the two of you will connect straight after. All I would say for now, though, is that as part of the work that we will be, again, publishing at the end of next week, one of the things we're clearly going to be addressing is the fact that the physical health of people with learning disabilities is systematically neglected, as you know, when it's health checks, primary care, and the same, by the way, also goes for people with severe and enduring mental health problems, where the 15 to 20-year life expectancy gap exists. So again, if integration means anything, it has to mean doing things about that.
Layla, did you want to add something briefly to that?
The only thing I would probably add is that I think the point I made already, which is that some of the challenge is about having people within the organisations that are attuned to the issues for those people, because you exclude people from the workforce and you don't know them, you don't know who they are, you don't know what they want, you know nothing about them. So I think part of this drive is to say there are people who are not invisible, who have real needs, where there's a massive inequality in health, and if they were part of the workforce, we all would have them on our radar and think about their needs in a different way. We just would, because they would just be they would be people that we know and work with, and they would have opinions that we would listen to. It's just fairly basic, really.
Thank you. Lady over there. Yes.
I'm Camilla Child from the Tavistock Institute. I just wanted to make an observation about some of the things I've really heard coming through this afternoon, which is about really involving patients, public citizens in decisions at all levels of decision making. And just wanted to know, I've already met lots of people this afternoon, or several people this afternoon, who are, and we need to join up all those professional voices with citizen voices. And just to shamelessly plug another programme that is funded by NHS England, which is called NHS Citizen, which is about bringing public voice closer to decision making.
Is it a way that you can communicate your experience?
It's a way of putting public views into a process which will result in on November the 25th, actually, with the board members here, engaging in different kinds of conversations with citizens.
NHS
around
Citizen. So use that service if it's online,
Yeah,
presumably,
it
and you
is,
can
yes.
submit your. Okay.
Thank you.
Yes, and your point.
Hi, good evening. Charlotte Alsani, I'm a GP. The pace of change has been phenomenal. I'm just wondering what practical advice you'd give to the patients in the audience this evening about how they can influence their healthcare going forward.
Yeah, thank you. Perhaps we could start there. How do you influence your healthcare going forward? Simon, other than using your...
Why don't we start with Paul and Chris, and then, I'll have to weigh in.
So I think those, the way to think about influence is the personal, the local, and the national. And initiatives like NHS Citizens, I think, are hugely useful in bringing together communities of interest, people who want to participate, not just as patients, in inverted commas, but as citizens. I think at the local, there are increasing mechanisms where we want to encourage people with their own experiences to engage with it, whether it's at CCGs or in health and wellbeing boards, who play a really vital role in this. Jackie Dyer, my vice chair, has been absolutely brilliant in making sure that we tackle issues around inequality of access, but also inequality of voice, as you've heard earlier. And then at the personal, every single interaction between a patient and the system has an opportunity to comment, to improve, to change the nature of those relationships. And I think whether it's in a formal structure like friends and family or in much more informal ways, that's the kind of dialogue that I think increasingly we're going to see. This is an evolution into a revolution around how people are able to engage with their services. And that's the shift in balance of power that I think is, to me, at the heart of what the 5-year forward view is all about.
Chris?
I think in the case of diabetes, it's absolutely crucial. This is a self-managed condition. On average, somebody with diabetes will see a specialist for 1-2 hours a year. The other 3,800, they'll be managing the condition on their own, which is why an uptake of structured education, which is around 4-5%, just simply isn't good enough. So we really have to understand how we connect people with diabetes with the information that they need to fully be able to manage their condition. There are plenty of resources available to that, and as Paul said, some of that is individual, some of it is connecting, for example, in our case with Diabetes Voices, to play a wider role. But clearly, I think we also have a duty to think about what we can do in support of people knowing more and managing themselves in a condition like diabetes, because clearly the huge costs that we know accrue in terms of complications, that there's a huge avoidable, preventable opportunity, but it largely comes down to empowering patients and activating patients to take a role in that.
Thank you. Simon, just one final thought from you before Malcolm Grant comes up and concludes, which is that I don't want to put a down on all of this, but, you know, the winter is coming. There are hospitals, good hospitals, who are facing, you know, are in terrible binds in terms of deficits and staffing, and, you know, it is such a difficult climate. Do you feel that at this point you are on track? It's early in the 5-year forward view, but...
Well, I think both Jim and I have acknowledged a number of times this afternoon that it clearly is difficult, and anybody who says it isn't, as I said, doesn't know what they're on about. So let's be clear about that. The question is, where do we go from here? Do we have a sense of direction and mobilize behind it? Or do we kind of just look, you know, can we look beyond the end of our noses? And people want to look beyond the end of our noses because they can see that more of the same is not going to work. Therefore, let's get on with the journey we're all committed to.
Thank you very much. I'd like to thank you all and to thank you for your questions, whether they were sent in advance or submitted here. Everyone is going to get an answer, which will be published on the website. So thank you very much, and I'd like to invite Malcolm to close the AGM.
Well, in closing tonight's AGM, it falls to me simply to say a few words of thanks. First of all, to Michelle for her excellent comparing of this evening. Thank you so much for that. And coupled with that, to the members of our panels, who I think have set the tone and I think explained so accurately what it is we're trying to do with NHS England, albeit at least 2 or 3 of them haven't yet started in jobs yet. So next year we'll be able to confirm promise against reality of delivery. But it allows me also to say on behalf of the whole board something that is absolutely essential, which is how much we value the work of our own staff. This pace of change is relentless. There are big wheels of change intermeshing. We haven't even tonight touched upon the devolution agenda, which is another great change that we know will bring about improvement of experience to patients. So for all of our staff who have worked to make this possible, who have worked long hours under pressure, and who have been very stretched by this agenda, we, the board, are immensely grateful, and I do wish that message to go out. I would couple that in particular with our thanks to Paul. The brilliance of his presentation tonight should not obscure the brilliance of his technical capability as our finance director, and the team that he's led, the production of our annual report and accounts on time, filed with Parliament on time, with a positive, or as positive as possible, a review from the National Audit Office as we could expect, is a great tribute to the quality of the staff we're fortunate enough to employ. I want also to couple that my own personal thanks to members of the board, particularly the non-executive directors who have been true in providing unswerving loyalty to their chairman for some of the time, but also have provided excellent challenge to the executive team led so brilliantly by Simon. Tonight I want publicly to acknowledge the contribution made by those who are standing down from the board. Ed Smith, who I mentioned before, and I couldn't be more delighted that he's taking on that really difficult role with NHS improvement. Kieran Devane stands down from the board at the end of the year. Amongst the national directors, we're losing Dame Barbara Haken, who's had over 35 years as a full-time loyal servant of the National Health Service, and I think is in need of some reprise. Barbara, a fantastic contribution. We're grateful to you. And Tim Kelsey, Patients and Information, who has decided against all the odds to accept a job in Australia for some reason, cricket and rugby. Somebody had to mention cricket tonight, given where we are. But Tim, we're grateful to you for all that you've done, and they will both leave us at the end of the year. And then finally, my very grateful thanks to everybody who's come tonight. We've had, I think, an immensely instructive and informative annual general meeting. It makes me personally immensely proud of the organisation that I'm privileged to chair. And in closing the AGM, may I remind you that questions and answers will continue informally as we mingle now, and those we've received in writing we'll put up on the web and we'll provide answers to those. But with all of that, thanks again to everybody, and I declare the annual general meeting closed. Thank you.